Good afternoon, everybody. It's really a great honor and pleasure for me to be actively involved in the Transplant-Child organization. So next slide, please. So, hematopoietic stem cell transplantation is the best and sometimes is the only curative therapy for many diseases affecting the hematopoietic, the immune, and the metabolic system. And the first task that we have to deal with when we have a patient who is a potential candidate to this kind of procedure is to identify a suitable donor. A donor that can be either HLA genoidentical sibling, and in that case we speak about a so-called matched sibling donor, or an unrelated donor that is a donor picked up among the unrelated donors registry volunteers that are spread all over the world. Despite of this, there is still a proportion of patients who needs an hematopoietic stem cell transplantation, but who actually lacks a suitable donor. And for these patients, the two options that we have available that we generally refer as alternative donor transplant are represented by a transplantation from an haploidentical related donor, the so-called haplo, or a transplantation from a cord blood unit. Next slide, please. So how big is that problem? So the first place where we look in order to identify a potential donor is the family. And the opportunity between two siblings to be HLA identical, since these genes are inherited according to the canonical Mendelian law, is about 25%. And we know that obviously with the increase of the number of siblings, also the probability to have an HLA matched sibling donor increase. Next slide, please. Okay. However, in Italy and in all the Western countries, we are seeing a decrease in the birth rates. And so actually the proportion of patients able to achieve transplantation from a matched sibling donor is less than 20%. It has been estimated according to a recent analysis performed among the group of the Italian stem cell transplantation of approximately 17%. Next slide, please. For all the other patients, the option, the main option is represented by the search of unrelated donor in the registries of volunteers donors. And in 2024, it has been estimated that more than 40 million of donors are enrolled in this. Next slide, please. However, the opportunity to identify an unrelated donor is dependent from the ethnic background of the patient, because for some ethnicity we have a likelihood to identify a donor that is over 60–70%, but for others this probability drops down to 20–30%. And if we look at the opportunity to identify a donor that is younger than 35 years old, that are basically the donors that we prefer because the younger works better, this difference is even more marked. Next slide, please. So the option that, as I mentioned before, the options that we have available are for these patients that are a percentage of patients that changed according to their ethnicity, are represented by the haplo transplant or the transplantation from a cord blood unit. Next, please. As you can see from these graphs showing the number of hematopoietic stem cell transplantation performed in Europe over the years, you can see that the preferred option has been starting from 2010 to undergo to an haploidentical stem cell transplantation. And for cord blood, instead, we have seen starting from 2008 to 2010 a decrease in the number of of the procedures, with very few transplants performed in the past 3 or 4 years. Next slide, please. Okay, so let's start from the first option, that is the transplantation from an haploidentical donor. So who is an haplo donor? An haplo donor basically is a subject sharing with the recipient just one haplotype. So basically 1/2 of his genetic background of HLA. And so he can be either in a parent, or in the 25% of the case, again, because these genes are inherited according to the Mendel's law, can be a sibling, or this is not our case as a pediatrician, but for adult patients, it can also be a daughter or a son. Next. In order to perform successfully an hematopoietic stem cell transplantation from an haploidentical donor, is important somehow to cross the HLA barrier in order to do so without increasing the risk of GVHD. The strategies that we have available are mainly represented by the ex vivo manipulation of the graft, or by an in vivo modulation of the graft, in order to reduce as much as possible the graft versus host effect. Next. So the first attempt to perform an haplotransplant date back to the 1990s, when the group of Perugia showed that it was possible to perform an haploidentical stem cell transplantation by administering to patients affected by leukemia a full mielablative conditioning regimen, followed by the infusion of high dose of CD44 selected cells, without giving the patients any sort of immunosuppression after the transplant. This approach was important because basically was the proof of concept that it was possible to restore the hematopoietic function also in case of a haploidentical donor, but at the same time highlighted two of the main pitfall of this kind of approach that are related to the T-cell depletion, because the T-cell depletion resulted in a rather high risk of developing opportunistic infection, and more importantly also into an increase of the relapse risk related to the fact that by removing T-cells and reducing the graft versus host disease effect, also the graft versus leukemia effect was impaired, and so also the risk of the failure of the procedure were higher. Next, please. So the next evolution of the haplotransplant was by ex vivo manipulation, was not to completely deplete the graft for all the T cells, but just of the cell population, of the T cell population responsible for the graft versus host disease effect. And so this strategy, based on the TCR alpha beta CD19 depletion, was started. And in that case, again, the patient was not given purified hematopoietic stem cells, but a graft that was depleted of alpha beta CD19 cells, by leaving in the graft both gamma delta T cells and NK cells, actually protecting the patients both from the risk of the relapse and from the risk of developing serious infectious complication. Also in this case, no immunosuppression was given after the transplant. Next. So this platform that was mainly developed by the group in children was developed by the group of Franco Locatelli in Rome, showed very good results in the treatment of pediatric patients affected by acute leukemia, giving an overall survival at 10 years of over 75%, a disease-free survival of approximately 72%, and a graft free, relapse-free survival, that is actually the goal of our treatment, that is the survival without any sign of long-term toxicity and of the relapse, of over 65%. So basically showing that this approach resulted in very high cure rate. Next. The very low incidence of GVHD with this approach also pushed the same group to test this approach also in non-malignant disorders. And these are the results of a retrospective trial performed in a population of patients affected by different non-malignant diseases, as for instance SCID, severe aplastic anemia, Fanconi anemia, and so on, showing a very good disease-free survival of over 90%, and also very low rate of GVHD, acute GVHD of approximately 13.1%, and in these casuistics, no case of chronic GVHD. Next. We tested, we also in Italy, in the Italian group of pediatric hematology and oncology, we also tested, we compared the prognosis of patients undergoing to TCR alpha-beta CD19 depletion transplant to the prognosis of patients undergoing to matched unrelated donor transplant, basically finding no differences at all, showing basically that this approach is able to give the same results of a more standard strategy. Next. So the other option that we have available in order to perform an hematopoietic stem cell transplantation in an haplo setting is by giving to the patients, after the infusion of the graft, high doses of cyclophosphamide. The cyclophosphamide that is given at day +3 and +4 after the transplant is able basically to eliminate alloreactive T cells by leaving non-alloreactive T cells, making them able to fight both the disease recurrence and the infectious complication. This approach was basically performed for the first time in the adult population by the group of Baltimore in Leo Lutznik with a non-myeloablative conditioning regimen based on cyclophosphamide, fludarabine, and a lymphodepleting dose of total body irradiation. Next, please. In Italy, again, we tested this hypothesis, the hypothesis of the PTCy transplant, haplotransplant in pediatric population, finding good results in terms of overall survival, progression-free survival, and incidence of graft versus host disease. The next. Also in that case, we went back to see if there were differences in the prognosis of patients undergoing to haplotransplant with performed with this strategy, with the PTCy strategies, compared to the conventional transplant, basically finding no difference, again showing that also this approach is feasible and produce the same results compared to the standard approaches. Next, please. What about the role of PTCy in the treatment of thalassemia? This approach has been tested also in this setting with good results because no graft failure was observed. The overall survival and the event-free survival of this population were good, 96%, but in that case, in order to limit the risk of graft rejection, peripheral blood stem cells were used with doses that were pretty high, approximately 10 millions for kilogram recipient weight, and that resulted in an increase of both acute and chronic GVHD. Next. Okay. The same approach has been also tested in the treatment of sickle cell disease. We know that sickle cell disease is a typical disease where it's pretty hard to find an unrelated donor because these are patients belonging mainly to African ethnicity, and we know that this ethnicity is underrepresented in the bone marrow donors registry. And so haplotransplant is really can be really an option for these patients. Again, in this trial, the role of the PTCy was tested with good results in terms of survival and GVHD. But in that case, a pretty high rate of graft failure was observed, approximately 42%. And so, next slide, please. Next, please. Okay. And so, in order to overcome this limitation, several options have been tested. One of them was to increase the dose of total body radiation from 2 grays to 4 grays. And that resulted in a reduction of the graft failure, approximately 6%, with pretty the same results in terms of both acute and chronic GVHD. Next slide, please. Okay, so another option that has been tested to overcome the problem of the graft rejection with the PTCy approach in sickle cell disease has been the addiction in the conditioning regimen of a thiotepa, that is a chemo agent with a very strong immunomodulatory effect, and in that case also the post-transplant GVHD prophylaxis with calcineurin inhibitors was changed with an mTOR inhibitor. And next slide, please. Next, please. And that resulted in an engraftment in 93% of the cases, again with a very low rate of GVHD, with an overall survival at 3 years of 100% and an event-free survival at 3 years of 93%. Next slide, please. Also, the approach with the PTCy was tested also in severe aplastic anemia. These are the results of a prospective phase 2 study performed on 27 severe aplastic anemia patients with a median age of 25 years. 35% of them belonged to underrepresented ethnic background. And again, also in that case, by giving the patients 4 gray of total body radiation instead of 2, the graft failure event-free survival was approximately 100%. So very good results. Next slide, please. Are all diseases the same? Actually, the answer is no, because there are some diseases, as for instance Fanconi anemia, where the the approach with the PTSI doesn't seem to work as well as, for instance, the TCR alpha beta CD19 depletion. These are the results of a retrospective study run by the Pediatric Working Party and Severe Aplastic Anemia Working Party of the European Bone Marrow Transplantation Group, showing that in case of Fanconi anemia, the PTSI was related with an increased graft failure, a reduced survival, mainly because of an increased acute and chronic GVHD. Next slide, please. Are the two approach ever been tested face to face? Actually, they have been tested. These are the results of a very recent study, again performed in Italy, where we went back to see if these two approach performed in case of the failure of a previous transplant were equal. And actually, in this trial that enrolled approximately 120 patients, we were able to demonstrate that the prognosis was pretty much the same compared in case of, including in case of malignant disease, the cumulative incidence of relapse. But again, in case of the PTSI was related to an higher rate of GVHD, both acute and upon whole chronic. Next. What about the old Perugia protocol? The same group of Perugia went back and they slightly modified their protocol based on the infusion of CD34 positive selected cells, and they combined it by the infusion of, after the transplants, of T cells, conventional T cells, in a regulated way with the selected dose, preceded by the infusion of Tregs. And in that case, they show good results. These are the results of the pediatric study, enrolling approximately 20 children, affected basically by almost all by leukemia, showing a chronic graft versus host disease relapse-free survival of 79%, showing that also in that case it is possible to perform this kind of transplantation. Obviously, this is very it's an approach that requires a skilled team, and that is not feasible everywhere, because you have to select the cells to infuse them, so it's not so easy and not so reproducible all over the world. Next slide. Next slide, please. Okay, what about the cord blood transplantation? We have seen that the second option that we have available for patients in need of an hematopoietic stem cell transplantation, but who actually lacks a donor, is represented by the transplantation from a cord blood unit. Why the cord blood unit? Because we know that during the embryo lives, the site of the hematopoiesis changed, and so at the birth of the baby, inside the cord blood, some hematopoietic stem cells are present, and they can be stored and frozen in order to perform an hematopoietic stem cell transplantation. Next slide, please. Next, please. Okay, these are the milestones of the cord blood hematopoietic stem cell transplantation that actually started in the 70s with the studies and in the 80s with the studies where we identified the hematopoietic stem cells both in the bone marrow and also in the cord blood. The first clinical transplant was performed by the group of Eliane Gluckman in Paris to treat a patient affected by Fanconi anemia, and then in the 90s, we started to perform this kind of transplant also in the unrelated setting. The cord blood banks network was established, and so achieving a large number of this kind of procedure. Next slide, please. Next. Okay, now we know that there are a lot of patients that have been transplanted from cord blood, and it has been demonstrated that the transplantation from unrelated cord blood unit is able to give the same results compared to bone marrow. And this has been demonstrated both for patients affected by acute leukemia and, next slide, for patients affected by non-malignant disorders. Next. Okay, and these are the results of the retrospective analysis in non-malignant disorders. Next. So what are the advantages of cord blood? So basically, the main advantage are represented by a rapid availability, because the cord blood units are stored in the cord blood bank, and they can be given in very short time. And the other big advantage, the big strengthness of the cord blood is that the cord blood is related to a lower risk of severe GVHD despite the HLA disparity, because it has been proposed that these cells have an increased plasticity due to the fact that they are very young, and so they can they are related to a reduced incidence of GVHD. The main disadvantage of the cord blood is represented by the fact that in the cord blood unit we have a limited cell dose, and that results in a delayed hematological engraftment and sometimes in a difficult immune reconstitution. Next. Next, sorry. Next slide, please. So these are the results of the cord blood transplantation from unrelated donor in Italy, showing basically an overall survival of 52%, a disease-free survival of 49%, and a transplant-related mortality that, for the reason I mentioned before, that are the delayed immune and hematological recovery, that is a little bit higher compared to the other kind of transplant, included the haplo. The very interesting data is the relapse rate, that is 20%. That is very similar to the ones of the other kind of transplantation. Next. Especially the data about the relapse incidence is very encouraging, especially for the advanced disease phase. This is an analysis that we have run again in the Italian Association of Pediatric Hematology Oncology, and we, in that case, for patients, the advanced disease patients are patients that have already failed one or more previous hematopoietic stem cell transplantation, or that started the conditioning with still pretty high disease burden, that means not in remission at the time of the transplantation, and in that case the incidence of relapse is less than 30%. That is a it's very good data compared to all the other approach. Next slide, please. And this data has also been confirmed by other group. These are the results of a retrospective trial performed in UK, where they compared the prognosis of a cohort of patients affected by high-risk pediatric myeloid malignancies, transplanted either from a cord blood unit or other cell source, including the haploidentical donors. And actually, the authors concluded that the cord blood was related to a significantly higher relapse-free survival compared to all the other procedures. Again, these are high-risk patients. Next slide, please. Next. Okay, what are the reasons of this very strong graft versus leukemia effect that we observe in case of cord blood? But we know that one of the mechanisms that leukemia has in order to elude the immune control of the transplant, of the graft, is represented by the downregulation of the HLA molecules. And according to this trial that has closed to the enrollment, and we are waiting for the result. We are waiting for the publication, show basically that cord blood seems to be the stem cell source less prone to this kind of phenomenon compared to the other. Next. So we have seen that the cord blood is related to a delayed hematological recovery and a delayed immune recovery. But several solutions have been tested in order to overcome this pitfall. For instance, for the delayed hematological recovery, the double cord infusion, the cord blood ex vivo expansion, or the intrabone cord blood injection were tested. And for delayed immune recovery, apart from the introduction of novel drugs, as for instance letermovir, able to really reduce the incidence of some of the complications related to delayed immune recovery, but also the opportunity to generate from cord blood unit T cells that are able to fight this kind of infection. Next. So the double cord, the experience with the double cord. So basically the idea behind the double cord hematopoietic stem cell transplantation is to increase the pool of the hematopoietic stem cells by giving two cord blood units instead of one. That basically by shortening the time of aplasia. This approach has been tested in this prospective phase 3 study that showed basically that the patients undergoing to single unit cord blood transplantation were the same as the double cord, as the double unit. That because, yes, the infusion of the two units correlated with a reduction of the aplasia phase, and so the hematological recovery was faster, but at the same time also the GVHD risk increased, and so at the end of the story the two approaches showed the same results. Next. What about the expansion? So the expansion, basically the idea is to take the cord blood unit, to treat it in lab by increasing the number of stem cells and to give it back to the patients. Again, with the idea to make the engraftment faster and the immunological recovery more rapid. This approach basically showed the same results as the double cord, because yes, we observed a reduction in terms of aplasia phase, but at the same time an increase in the GVHD. And more importantly, all these trials enrolled mainly patients older than 12 years old, and so not a proper pediatric population, not exactly a pediatric population. Next slide. Next, please. The other option that has been tested in order to reduce the time of the engraftment was the intrabone injection. Cord blood usually is given to the patient by IV injection as any other kind of transplantation. The group of Francesco Frassoni and Andrea Bacigalupo in Genova tested this approach in the adult population. At our center, we tested the safety and the feasibility of this approach in the pediatric population. We treated the 9 patients, basically showing that this approach was feasible and safe in the pediatric population, but without observing any big effects on the engraftment. Something maybe on the platelets, but for the neutrophil engraftment, it was pretty much the same as the regular IV injection of the cord blood. Next. Okay. So I told you before that one of the main pitfalls of this approach of the cord blood is represented not only by a delayed hematological recovery, but also by a delayed immunological recovery, resulting in an increased risk of developing infectious complications, as for instance viral infection or reactivation. It was shown, some groups showed that it was possible to use just the 20% of the cord blood unit in order to generate T-cell lines that are able to treat this kind of infection in case the patients develop them after the transplant. And so this is another option that we have available in case of the patients has these kind of problems. Next. Next slide, please. The cord blood and the PTSI have been ever compared. Yes, these are the results of a retrospective trial performed in the EBMT. Basically, result that showed basically that the leukemia-free survival, the overall survival, the relapse incidence, and non-relapse mortality were pretty much the same. But again, the cord blood was the haplo was related to an higher risk of GVHD. Next. We are coming to the conclusion. So at the end of this presentation, I think that what I hope to have transmitted to you is that the outcome of the transplantation from alternative donors is the same as the one that from sibling donors matched unrelated donor. Both haplo and cord blood have strengths and weaknesses, and they are not equivalent in all the situations. The decision to proceed with one or to the other depends on patients and disease-related factors that should be carefully considered in planning the strategy to treat the single patients. And with these slides I have done.